This session will focus on who is affected most when measurement policy and service design fall short. We'll explore how inequities in reproductive health access emerge and how they can be addressed through community engagement, trauma-informed practice, and inclusive systems. Our 4 presenters bring unique perspectives from community leadership, refugee health, disability and sexuality research, and psychology. Each will deliver a short rapid-fire presentation before we open the floor for questions. Please submit your questions through Slido, and I'll try my best to use it. Our first presenter is Lana Bentley. Lana is the Executive Director of the Women's Centre of Calgary, part-time instructor at Mount Royal University, and board member of Youth Central Calgary, the College of Opticians, and the Black Heritage Committee at Heritage Park. Lana's work bridges community, education, and policy while advocating for inclusive systems that meet women where they are. Please join me in welcoming Lana Bentley.
Thank you so much. I've sort of reached that age where now when I listen to my bio, it's like, I'm just really old. So I'll advance the slides now. Oki Tansi, hello, my name is Lana Bentley, and I'm here today on behalf of your friendly neighborhood feminists at the Women's Centre of Calgary. First of all, I'd like to say thank you so much to the organizers for including us today. I can't tell you how much it means when you're doing this work to truly be among friends. For those unfamiliar with the Women's Centre of Calgary, we are a unique organization. We're actually the only drop-in women's centre in our city and one of 3 in the province of Alberta. We offer a safe place for women to get assistance, connect with others, and work for change. In terms of who we serve, there's a bit of a change to this slide as I just actually got our most recent numbers. We've seen a 40% increase since last year, and as we head into the busiest time of year, November and December, we've actually served 10,500 unique individuals, 48% of whom are newcomers and immigrants, 12% identify as Indigenous, which is an increase from 2024, 7% identify as being a member of a gender and sexually diverse community, and 3% identify as having a disability. The majority of the women we serve, including those who work, are of low income. In March of this year, friends, we introduced a crisis navigation specialist, and on her own, she has already seen just over 530 women. Most of those women have come to seek support around mental wellness, homelessness, poverty, and very concerningly, 30% of them indicated that their primary concern was domestic violence. And as we all know, domestic violence is a driver into homelessness, so the number's actually probably higher. Now, before I go any further, I do want to say that although the women we serve, based on their circumstances, can be described as vulnerable, their personal characteristics make them, in my opinion, resilient, and the ingenuity that they possess and put to work to make ends meet, it's amazing to watch that, and it's a privilege to be a part of those journeys. Though the Women's Centre of Calgary is not a medical organization, we do play an important role for the women who walk through our doors around healthcare-related issues. We build trust, a sense of safety, and a sense of belonging, which arguably are key ingredients that empower women to access healthcare down the road. Many women come to the Centre for basic needs items, English language classes, or skill-building workshops, to name a few of the services we offer. But they leave with information about their wellness and resources, and more importantly, the confidence to make decisions for themselves. We often serve as a bridge between women and formal systems, including our healthcare system. Here's what we've learned regarding the barriers that women we serve face around access to reproductive health care, much of which I imagine already has been or will be discussed in greater detail today. Newcomers in particular may experience delays in accessing medical care during their settlement process due to the multiple demands that they're juggling or a lack of understanding about what they in fact are eligible to receive. Language and cultural mismatches can create confusion about contraception, menopause, or fertility. In the absence of a trusted voice, misinformation can spread quickly in diverse communities. Survivors of trauma may avoid medical care due to fear of re-traumatization or misunderstanding by their healthcare provider. At the center, the broader social trends are local realities. For example, we meet women who delay pap tests or skip prenatal appointments because of the various psychosocial concerns that they're managing. When your day is spent choosing between food or rent, reproductive care becomes a luxury. Every Thursday, we have more than 100 women come to our center for our Shop Day initiative. This is a program where you can drop in and grab up to 5 personal care items of your choosing for free. Most of the women who access that initiative come for diapers or feminine hygiene products. While I wish our center didn't have to fulfill this need, I'm certainly glad that we can, and we know all too well what period poverty looks like in real time in our city on a daily basis. When women feel safe, they seek care. When they feel connected, they ask questions. And when they trust a space, prevention begins. At the Women's Center, cultivating a sense of belonging is a powerful tool, and we use it every day. It transforms an innocuous visit for groceries into a conversation about contraception. And I just want to be clear, it's not that pipeline every time somebody comes in for groceries. Sometimes it is just groceries. But we believe that this, in part, is what public health can look like from the ground up and on the grassroots. In keeping with our mandate to work for change, we have a vision for women's healthcare that I imagine aligns with much of what has already been discussed here, applying a gender-based analysis to the likes of policy development and system planning, supporting low-barrier access to healthcare providers, engaging providers around trauma, around training for trauma-informed care and cultural humility, expanded access to contraception, and funding and resources for community-based access points. These are certainly not radical ideas. They're just sound measures that are based on research and practice wisdom. Finally, I will add that a unique feature of the Women's Center is that we are staffed by women, and our board is all women. This is by no means intended to diminish the contribution of men and gender-diverse persons, but representation truly matters, and it means a lot for people coming through our doors to see themselves at absolutely every level of the organization. We believe that healthcare access starts long before a medical appointment, and often it can start with people like us. Ensuring that vulnerable communities have access to reproductive care is not aspirational. It's a necessity, and women in Calgary deserve no less. To quote Rosemary Brown, "Until all of us have made it, none of us have made it." Thank you very much, and let's keep in touch.
All right. Thank you, Lana, for opening with that community perspective on access and inclusion. Next, we'll hear from Annalee Coakley. She is the co-director of Refugee Health YYC, the interim director of the Community Engaged Learning Program at the University of Calgary, and the director of strategic partnerships with the Society of Refugee Healthcare Providers. Her presentation focuses on the reproductive health of refugees and precarious migrants, who they are, the barriers they face, and how trauma-informed, culturally safe care can make a difference. Welcome, Lee.
So today, I'd like to speak to you about reproductive health equity for refugees and migrant women, where we create a world where no woman is left behind. I have no disclosures. We'll first talk about why refugee and migrant health matters. We'll talk about some of the barriers that newcomers face when they first arrive in Canada and ways in which we can overcome those barriers and improve health equity. And so why does migrant health matter? The last census shows that nearly a quarter of the Canadian population is foreign-born. So a quarter of the population are migrants. It's simply who we are now as Canadian society. And so if our public health system doesn't include migrants, we're doing a disservice and undermining all of our public health. The other reason why migrants and refugees matter, especially vis-a-vis women's health and reproductive health, is because, we've just published in The Lancet on the last 10 years of our work with the Calgary Refugee Health Program, and the median age is 24. And on an annual basis, we have about 60 to 80 new infants. These are Canadian infants born in our practice. And so migrants are young, and they are making babies. So there's not only the immediate impact, but the impact on future generations in Canada. And their journey as migrants is a key social determinant of health, impacting their health and well-being. And globally, migrants are one of the most neglected groups in societies. And there's an echo of that in Canada as well. So women's health is public health. Women's health shapes the health of families and of communities and societies. Maternal mortality and morbidity are sensitive indicators of a health system's strength. And women's health, as previously mentioned, is intergenerational. And so by improving access to prenatal care and contraceptive care, you improve the health of children over the long term and society over the long term. And in Canada, refugee women are 2 to 3 times more likely to experience delayed perinatal care, prenatal care, and unmet contraceptive needs compared to non-refugee women. And so why is this? The reason why this has to do with barriers to access. Sometimes those are administrative. In Canada, we don't include all migrants in our publicly funded system, so many people are excluded. For many refugees, they're covered under a different insurance scheme, notably the Interim Federal Health Program, which is a federal insurance scheme. And a lot of providers aren't aware of that program and often reject outright seeing refugee patients. There's also cultural and language barriers that people face. In Canada, we don't have universal, easily accessible interpretive services or cultural brokers. There's also the systemic barriers, and that would include things like trauma-informed care and racism that unfortunately, racism imbues all sectors of our society, including the health sector. And then the mundane but very important structural barriers, such as access to transportation, living life in poverty in Canada, income and food insecurity, and access to affordable childcare. And so what are the consequences of all these barriers? The consequences are delayed or perhaps denied access to reproductive health care. And we know that when access is delayed or denied, that leads to adverse outcomes due to missed opportunities to screen for health conditions and social conditions, missed opportunities to screen for infectious disease, anemia, malnutrition, domestic violence, social determinants of health such as poverty or income insecurity. And we know that this leads to poor outcomes in pregnancy and following pregnancy. And so what do? We need to have access to universal health care. If health is to be a human right, we must include everyone. Every resident in our society must be included in our publicly funded health system. We need to have community-embedded reproductive health services. We need to meet patients where they're at, and that's often not in the health system, it's in their community locations. We need to have universal access to affordable, easily accessible interpretive services and cultural brokers and health navigators for newcomers. We require cultural safety training and trauma-informed training for all health providers working in our system. And of course, as mentioned by many of our previous speakers, we need to collect the data, because if we don't have the data, we don't know, and we can't reveal these health inequities. And we need to include migrants and refugees, and specifically migrant and refugee women, in our health policy design, our research design, are at all levels of healthcare. We only design a system that works for us. And so if it's somebody like me designing a system, I've got a bunch of blind spots and I'll miss the people, I'll miss what I don't know. And so our vision of equity, it's not just charity, it's justice, but it's not just justice, it's actually an investment in our collective future. And in Calgary, we're actually a beacon of equity in Canada and around the world. So we've just recently published the data on our antenatal program at the refugee clinic, and we have proven through trauma-informed, culturally safe, community-embedded care, which is what we do at the Calgary Refugee Health Program, we have the exact same outcomes for our patients as the rest of our society, which in the literature is rare. And so what we need to do is we need to upscale the best practices developed here in Calgary to the entire health system. Thank you.
Thanks, Lee, for highlighting how systemic gaps translate into real-world health risks for refugee and migrant women. Our third speaker is Dr. Alan Santinele Martino, an assistant professor in the Department of Community Health Sciences and lead of the Disability and Sexuality Lab at the University of Calgary. Alan's research explores the intersection of disability, sexuality, and reproductive health, helping ensure that equity and inclusion extend to all bodies and experiences. Please welcome Dr. Martino.
Okay, thanks everyone. And I'm actually an associate professor now. Look at me. Yeah, look at me. Okay, thank you. Okay, so just a brief description. I'm a brown, bald man with round black glasses, and I'm wearing a blue mask over my nose and mouth. And as in the spirit of Mariah Carey, my hero, feel free to use the space in the way that makes the most sense to your bodies, to your minds. I'd like to highlight today how women with disabilities in the US and Canada face significant marginalization in reproductive health care. And I'll give you some examples from my own research and the literature. As of 2025, 1.3 billion people globally, or 16% of the world population, have significant disabilities, and women represent a large proportion of folks in this group. Roughly 12 to 15% of reproductive age women have a disability, and data from Ontario indicate that 1 in 8 pregnancies in 2017 involved a person with a disability. And yet, when it comes to access to services, we see that only 15% of women with disabilities use reproductive health services. 81% of those cite inadequate facilities as the main barrier to access service. Barriers include physical inaccessibility, negative providers' attitudes, lack of sign language or materials in plain language, and even social stigma. Women with disabilities in Canada are more likely to live in poverty and have chronic medical conditions, including diabetes, hypertension, depression, and many have histories also of violence and trauma. And these are all factors that contribute to poor maternal and reproductive health. Sometimes healthcare providers may wrongly desexualize disabled women, especially women with intellectual disabilities, seeing that women who are seen as not needing this type of care. Women with disabilities report that they have limited options when it comes to contraceptives. Sometimes practitioners, and I've heard that in my own work, practitioners are surprised that women with disabilities are sexually active and even fail to talk about contraception or STIs. Fewer than 37% of pregnant women with disabilities receive prenatal care, despite its known importance in this room. Disabled women are also less likely to receive routine preventive care. So, for example, compared to 75% of women without disabilities, only 61% of women received a mammogram in the US recently. And there are lots of challenges, even that are specific to subgroups when we think about disability. So really thinking intersectionally here. Deaf women, for example, frequently report communication obstacles. A systematic review found communication barriers were the most cited obstacle to contraceptive use among deaf women. or women with intellectual disabilities, who often received contraception without full explanation or informed consent. Providers used language that was just too complex to understand and did not discuss side effects or alternatives. So I'd like to give you a couple examples here from my own work too. But before that, with my colleague here, Erin Brennan, we also did some work around looking at medical students across Canada and what is their knowledge around disability and sexuality, and what are their attitudes as well. We found that most students held supportive views on the sexual rights, parenting, potential sexual expression of people with disabilities. However, only half said that their curriculum, over half said that the curriculum lacked adequate training on disability and sexuality, and many felt unprepared to discuss reproductive health with disabled people. The other thing that we cannot refuse, we can avoid to talk about is forced and coerced practices. The forced sterilization of women with disabilities remains legal or permitted under guardianship in many countries, and we see cases even in Canada where the legal guardians of women with disabilities will authorize procedures like this, even though these are violations of women's rights and recognized as having lifelong impacts on mental, physical health, and autonomy. Even when you look at states that allow disabled people to be sterilized without consent in the United States, it's a very scary number. Like, these are the yellow zones. We like to believe that Canada, we're far ahead of the others, but we're not sometimes. As Mia Mingus, an amazing scholar and activist in disability justice, says, eugenic science is still vibrant, part of US culture that interacts with and shapes the reproductive lives of disabled women in many ways. Several states still allow family members or care providers to request their sterilization of people with disabilities under guardianship. Guardians also make decisions for the person, sometimes about contraceptives, abortions, sex education, and other key factors. So let me give you a couple examples here of interviews I've done. I talked to Alice, a direct care worker with people with intellectual disabilities, and she told me, double shot is so common. Every girl who could potentially be sexually active, whether or not she is on the shot. Like every single woman of childbearing years who I worked with who had the potential to have sex was on the shot. And this is something that we see in the literature, even in my work. 90% of women with intellectual disabilities, whether or not they're sexually active, they're being put on birth control. And the issue is not birth control per se. The issue is that we often talk to women with intellectual disabilities and they don't even know that that is birth control, or not a part of the decision-making process of deciding which method, what are the side effects, what are the pros and cons of different ways. And that's, to me, is the problem. And then I asked Alice, so do you think people know what is happening? And then that's when she explains, it'll be really passively aggressively put across, manipulated into thinking that you made that decision as a disabled woman to go on depot, but really it wasn't. It wasn't your decision. Sometimes putting women with disabilities for birth controls, sometimes it's justified as they cannot handle this messy time of the month. And this is the language that has been used. So let's just make life easier for women. One final example here. I talked to Rose, another support worker. She was telling me about a couple with intellectual disabilities who got caught making out in a basement. That triggered a whole bunch of different consequences in the lives of the couple. She says her family was so angry and they moved her out of the community and she had a procedure. Whatever they did to us was, she asked me, what's the proper term for when you remove someone's sexuality, like the reproductive parts? I say, like sterilization. She responds, yes, that's it. I remember this young lady told me about this. When she explained to me, she seemed quite okay with it. Of course she would be. The way, I don't think she understood what that meant. And the number of cases that I hear like this, it's really terrifying. There are lots of things we can do. First of all, we need to support decision-making and share decision-making in the lives of women, people with disabilities in general. Think outside the box. Use plain language, accessible formats to allow people to make choices. Make health spaces accessible to people. Challenge discrimination and bias. act as allies, supporting the rights and making sure that human rights violations are not happening even now, and co-design services with disabled people. And I'll end just by sharing what my student, Eleni Momos, created. One is about how to make your medical office more accessible. Here are some tips for doctors, and what to expect for your first pap smear for women with disabilities who might not know what the process will look like. So let's think creatively and outside of the box. Thank you.
Thank you, Alan, for the reminder that visibility and inclusion must extend across all aspects of reproductive health. Our fourth and final speaker, Dr. Lauren Walker, a registered psychologist and adjunct associate professor in the Department of Oncology and Psychology at the University of Calgary. Lauren is engaged in developing trauma-informed care guidelines for pelvic health, reframing how clinicians approach intimate, often vulnerable procedures and conversations. Please join me in welcoming Lauren Walker.
Thank you for having me to speak today. I'm going to talk about becoming trauma-informed. I would argue that this improves healthcare experiences not only for vulnerable populations, but for everyone. So as mentioned in the introduction, I am specifically focused on bringing trauma-informed care practices into pelvic medicine. So we'll start first with the rationale about why this is particularly important. We know that trauma can be associated with avoidance of preventative care and screening. And we know that when medical procedures are offered, they are often complicated in the presence of distress and trauma. And again, I would argue both for the patient and for the provider. These aren't situations where people feel comfortable and confident. We also know that providers and patients can experience re-traumatization. So many of you in the room are providers, but you also are human beings who may perhaps have your own trauma histories. So let's review what trauma is. So this includes an individual event or a series of events that is experienced by a person as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on a variety of areas of the person's life, including mental, physical, social, emotional, spiritual well-being and functioning. And I would argue that pelvic health care has specific vulnerability associated with sexual and medical trauma. While all types of trauma are important when we are considering the invasive and sensitive nature of care that is offered to folks in pelvic health, sexual and medical trauma are particularly relevant. So let's review again with sexual trauma. This includes harassment as well as assault, including comments, jokes, threats, behavior, and unwanted sexual contact. With medical trauma, this might be a newer term. This encompasses emotional and physical responses to a negative or traumatic experience that occurs typically in a medical setting. And this may relate to pain, injury, serious illness, diagnoses, medical procedures, and frightening treatment experiences. So you can see quite a broad range here. And trauma can be a single incident in that it's acute. It can be multiple occurrences in that it's chronic, or it can be multiple different traumas, which can result in complex trauma. So in a review of the prevalence of trauma, we know that 20% of girls and 10% of boys will report childhood sexual abuse. This might be an underreport. 30 to 50% of adult women will report experiencing sexual assault at least once in their lifetime. And when particularly looking at vulnerable populations, we know that sexual assault rates are 4 times higher in transgender people, 3 times higher in Indigenous women, and 2 times higher in people with disabilities. We know that 20% of patients will experience medical trauma, and again, I think we might continue to see that number rise as understandings of medical trauma increase. So I'm going to speak to you a little bit about a project that we've been leading to bring trauma-informed care practices specifically into pelvic medicine. And a guiding framework that we've used is the Substance Abuse and Mental Health Services Administration Guidelines. This is an excellent document geared toward behavioral health, so particularly mental health and addictions, and we've been working to adapt that more into medical practice. So this document describes 6 principles of trauma-informed care, largely focusing on collaboration and mutuality, safety, empowerment, voice and choice, and trust and transparency within the healthcare provider relationship, but also prioritizing peer support and cultural, history, and gender-related issues. As an acronym to remember, an easy one is the 4 R's, which includes realizing the prevalence of trauma, recognizing the impact of trauma, responding appropriately to individuals with trauma, and resisting re-traumatization. And again, I would say this occurs on a systemic level as well, so for both providers and patients. There are many barriers to providing trauma-informed care. I could probably extend this list quite extensively. But these can include seeing trauma-informed care as irrelevant to one's practice area. It can include a lack of knowledge or skill in implementation, time constraints and competing demands at what to do in a visit, and feeling responsible to treat or resolve the disclosed trauma. I've had individuals say, I don't want to ask if trauma is relevant because I would open up a can of worms that I now then can't contain, as well as personal discomfort, again, from our own lived experiences. So through this initiative, we are working to create a specific set of guidelines and recommendations that not only take what I have often heard from folks describing trauma-informed care as a set of soft skills. Isn't it just being more empathic or kind or taking more time with the patient? But we really challenge that, and we've worked to clearly operationalize strategies and techniques that can be used to introduce treatments in a more trauma-informed way. So in doing so, we conducted 30 interviews with patients who had a trauma history and who had accessed pelvic health care within the last 5 years. We used this information in combination with a working group of interdisciplinary providers. You'll see the list here of folks that are included in that initial working group to generate a set of guidelines and clinical recommendations. The generation was a sequential review process, with each individual adding more and editing and changing the guidelines, and then all participants engaged in final approval. What this resulted in was 9 practice areas. So what you'll see from this range of areas here is that this isn't just that direct point of contact with the patient. It begins as early as setting up the environment, introducing oneself to the patient, engaging in examinations and procedures, as also recognizing the integration of where trauma can directly impact those areas, inpatient settings recommendations, suggestions for documentation, how to query trauma, and how to respond to traumatic disclosures, as well as self-reflection. I'd like to give you a couple of examples. So I picked some particularly provocative examples. With environment, we suggest minimizing the visibility of potentially intimidating procedural tools and placing them out of sight if possible. With regard to introductions, explaining the purpose and asking for consent before asking potentially intimate questions, ensuring the patient knows that they don't have to answer. With procedures, explaining that the patient can stop an exam at any time and discussing ahead of time how they can both verbally and non-verbally withdraw their consent. And with documentation, documenting conversations and outcomes as they relate to the patient's decision-making and avoiding terms such as non-compliance or refusal, recognizing that there are socio-demographic and personal good reasons why people might refuse treatment. So I'm just going to leave you with a plug here that we are still continuing with this study. We are asking practitioners to engage by giving feedback on these recommendations, and we're assessing feasibility, importance, barriers, as well as intention to take up these practices. So there is a QR code here. If you are a provider in the audience, we'd love it if you could take, it is about 15 minutes to fill out the survey. We have received feedback that those who have completed it have actually learned a lot in the process, so it's a free source of education about trauma-informed care. There are cards around at the back of the room, and I might slip some onto some tables too, so if you missed this QR code, we still have access to it. We are also doing an ongoing patient survey as well, so we want patients to weigh in on these guidelines and recognizing that even though there are non-providers in the room, many of you are also experiencing and accessing pelvic health care. So our next stages are working to disseminate these guidelines once they are validated with various multidisciplinary organizations across Canada and the United States to start. Thank you very much.
Okay, this is your chance to ask the panel some questions on Slido. We've got about 15 minutes for questions. So I'll start with our first question. What all of you have highlighted are real and have been documented and observed by many researchers and providers in this room. How can we come together and build meaningful partnerships to drive real change towards equity? I'll open it up to the group, and if anyone in particular wants to answer, feel free.
I think first recognizing that there are many different partners doing this kind of work. I'm pleased to be invited to be a part of this panel because as listening to each of your presentations, I thought we actually should be connecting with each other. We're using the same language and we have the same values and priorities. So I think it first starts with recognizing that there are these other partners out there to connect with.
And I would agree. Like a session like this, which helps us come together and discuss our shared challenges and solutions to those challenges. This is a great first step, but I think it needs to be developed more on a higher level and ongoing, in an ongoing way where we can come together and advocate on behalf of our patients and women's health with the provincial and federal governments.
And I think transdisciplinary work is so important. Like I count myself very lucky to be a social scientist who's in a school of medicine and get to work with amazing OBGYN professionals, for example. These are conversations that wouldn't happen otherwise, but by being on this sharing the same floor, to having these conversations, we start to co-produce research and resources for the community that make such a difference. And I think it's very lucky to be in this conversation.
Thank you.
Sorry, I just felt pressured to talk because everybody else was kind of hanging back there. Yeah, so hundreds of years ago, I used to work for Alberta Health Services. At the time, it was Calgary Health Region. Perhaps some of you remember those lanyards. And when I worked at HS, I was an inpatient unit manager. I was there for about a decade, and that was my last stop. And geez, I wish we'd had this back then. The majority of kiddos in my unit didn't need to be there. They reached therapeutic value with their admissions quite quickly, but we just weren't able to send them home because of many of the issues that have been described today. So I know there's a lot of challenges, but I think that the fact that I'm here today with the Women's Centre just shows how much progress we've made in bringing all these voices together.
And just to add, I feel like the University of Calgary has done a lot of work over the past 10 years in connecting with community. Mm-hmm. Like, I think the fact that you're here, I'm not sure if this would, community would be so well represented maybe 10, 20 years ago. So those connections to community and inclusion of community in the work and embedding the work in community, all of that is key to moving our priorities forward.
Great point. Thank you, Lee. Okay, lots of questions coming in. For Dr. Martino, how do we improve medical equipment to support women with disabilities, for example, mammogram machines?
Mm-hmm. I think the good news is that we already have so many amazing disabled activists doing this work of educating, and it's just that we're not reaching those because a lot of people with disabilities are using podcasts, blog posts, right, books, comic books. I think we need to look outside of our comfort zone and look at this more creative material that is giving us already lots of suggestions. And at the end of the day, too, it's also about one-on-one conversations, too, about how can we make this space better for you? And be proactive, not waiting until someone comes to your space, but expect that people with the disabilities will come to your space. So how can we think in advance about access, accessibility, and all those things?
Great comment. Thank you. This is a question for Dr. Walker, and others feel free to chime in as well. What are your thoughts regarding lack of adequate pain control offerings for pelvic procedures? For example, like IUD insertions and some of the potentially negative effects from the pain and anxiety of such procedures.
Yeah, absolutely. When we think about that medical trauma definition, it includes experiences of pain. We know that people are going to be avoidant of putting themselves in a painful situation, of course. Why would we put our hand on a hot stove? But there really has not been enough attention given to this or enough resources or opportunity. I think I've seen on social media in the last like maybe 2 years, much more attention being paid to women's experiences in accessing care with pain specifically. And so instead of, and I actually find some of our female providers are great, and some of them are not so great. Some of them are like, oh, this is just what it's like to be a woman, like tough it out, which is really discouraging. So I do think that we are seeing on a patient level far more advocacy and really like unrest, not just sucking it up and kind of grinning and bearing it, but saying I need something more. And there really are great resources. I, as a therapist, do a lot of educating with my patients about what are some of the options, and can you ask your provider about these? So I think if we come up with some more systematized, like an algorithm or a checklist of starting with kind of the minimal level intervention as needed all the way to sedation if needed. But these are available. We just need to press harder to access them.
Thank you. For each panel member, so besides the practitioner's office, where is the best place that we can engage with your populations to provide them the information they need?
Well, I can speak to refugees. So in terms of the refugee population, like I tend to engage with resettlement organizations and community associations. And so I have found that going to the community and empowering, like oftentimes I will speak to, so I'm also very much engaged with international medical graduates because they often come from the same communities as my refugee patients. And to my refugee patients, they're not international medical graduates, they're just doctors. And so they're very respected members of their society, they're trusted messengers. And so I engage with international medical graduates to be the trusted messenger they're already connected to the community, and then they provide that information to the larger community.
Great point. Lana?
You could come to the Women's Center. Our comms coordinator would have a fit if I didn't squeeze that in somehow. Yeah, I mean, obviously I'm here representing the Women's Center of Calgary, but I also do believe in the ethos of Enough for All. There's so many wonderful community-based agencies that engage people not around crisis. And again, having worked in healthcare, I know that quite often that's how people would come across my desk. But geez Louise, what a difference it would have made if we had engaged them well before. And so community-based settings that are not necessarily medically focused, where people are coming, so we offer like yoga, Zumba, artist in residence. We have a lot of programming that's out of the conventional office or clinic as usual environment, and it's just a great place to connect with folks. And there's so many wonderful agencies doing that work in Calgary that I'm sure would love to have you all come. I mean, you might have to do a bit of Zumba, a bit of yoga, I don't know, but it's certainly worth it to do that relationship building and help enhance people's comfort and motivation to seek care.
Mm-hmm. Yeah, and I think it's about where you go, but also how you do it. And I think what I've seen in my work a lot is that we need a lot more plain language information being provided. We need much more thinking outside of the box about how we share information. For example, using more arts-based or creative approaches to doing this. As researchers, we need to really engage meaningfully with community, and a part of it is also asking community, what is the best way to engage and share information? And it's funny because two very quick examples. We talked to parents and caregivers of autistic teens about what is the best way to give information about sex and sexuality and sex education. And for them, it was very clear that those books, 60-page books, is not the best and most effective. Nobody has time for that. But they did enjoy the idea of having podcasts. 25 minutes, you're driving your kid to school, you can listen to it as you're going about your day or watching something, right? So that to me was, let's do it. So we created a podcast. Or even when we did a project with autistic adults about sex education and what is the best way to give that information, at first we thought maybe we can do dance. Like, dance could be so creative and interesting. And then our advisory group of autistic adults was like, we hate dance. In high school, they forced us to dance with each other. It was awful. Like, this is not consent. So we completely changed the project, and we ended up playing with Play-Doh. We did drawing, poetry, writing. And so I think as researchers, we need to walk the walk too, and be like, we need to share the power in terms of research and actually engage meaningfully the way that works for our community.
I'm so glad that that question was asked, because many of the people that you do need to access are actually not in the practitioner's office, and that's the problem. How do we bridge that gap? And so wonderful suggestions here. I was so glad to see Dr. Martino's infographics as the last slide of his presentation. We, a couple years ago, got the opportunity to collaborate on a presentation for a group of trainees in women's health, and we ended up doing a whole seminar on how to use social media to use it as a knowledge translation strategy. So I'd be remiss if I didn't remind folks that social media is actually a really powerful tool. People are on it and consuming all sorts of nonsense. And so if we can put some good, reliable, truthful, accurate content out there, we should be doing that.
Thank you. This is a question that might build on that a little bit. All of these points brought up are important to be implemented in physicians' work, but more importantly in medical and nursing schools before these students begin their medical practice. How do you all work with the medical school or the nursing school to do so, or how do you wish you could if you have been met with resistance?
I don't mind weighing in on this one first. Okay, so I love the opportunity that the next generation coming into med school and nursing school tends to actually be like on the cutting edge of a lot of these important concepts that we're talking about. And so I think there's a lot of enthusiasm, there's a lot of socially conscious awareness. And interestingly, I've had some conversations of late with folks who they kind of come into their programs and they're really excited. They maybe get some reinforcement through some theory and some book knowledge, but then they land themselves in a practical setting with preceptors who are maybe not practicing in this way. And so it's challenging, I think, for trainees to speak up and say, hey, that's maybe not the best way to be practicing, and so to challenge some of the mentorship or the real world experience that they're getting. So I think that's one of the challenges, but I mean, continuing to engage providers at every step of their lifespan, really. We need to be reinforcing these messages along the way so that our med school, our nursing school trainees are feeling empowered to be able to actually use the practices that they're learning about and that they're excited about.
I'm just going to add to that. So, I'm interim director of community engaged learning at the medical school, and so this is one of the challenges. I think is exactly what you brought up. Is some of the sort of the more dinosaurs like myself, like the older practitioners who went through medical school and training during different times, they've not been as ready to adopt the current practices or even understand why community engaged learning is important. And so, I think this is what our faculty development department is working hard on, is bringing all physicians along. I think that the way we choose our medical students has changed, and I think this is what's led to, I don't know, I've just met the most recent class, and they're super cool. They're very socially engaged, socially aware. They're interested in health equity and social justice. And so they're much more enthusiastic about community engaged learning. And so through this community engaged learning, which is part of the new curriculum, this is where students are embedded in the community. Overall, they do half days, for months. Throughout their medical education, and they're there to be with people. They're not there to fix problems, they're there to be with people and to learn and be curious and learn from the community partner. And of course, so many students are enthusiastic, but you always have like a minority of people who would rather know about the nephron. They really want to know more about physiology. And, and I empathize because I would have been one of those people back in the day. I wouldn't have gotten it when I was in medical school. I never thought about health equity, et cetera. And it's only through practice where actually my diagnosis and treatment matters not without food security, income security, healthcare coverage, et cetera. And so, only over time did I really understand the meaning of health equity and the importance of one's social context on health. Yeah.
I have a question that actually kind of builds a little bit, I think, on community engaged learning, which I'll just ask now, maybe Lee. So just a question about how you engage with community partners. So how you create those partnerships, how you embed community work into your practice or research. And anyone feel free to chime in, but building on that.
Yeah, and I'll just speak to my own experience. So fortunately, throughout my 15 years of experience working with refugees, we were initially embedded within a community agency. So we were embedded within CCIS, which is the Refugee Resettlement Agency. And through that agency, over time, we made other connections. And I think it's just building that trust. I think it was very, very slow, but then community then understands that you're a safe place to go to for help. And so suddenly then you have community members coming for various things. So most recently I had Immigrant Outreach Society reach out because they noticed a lot of the women from East Africa were being diagnosed with breast cancer at a fairly early age, at a late stage, and they've never had breast cancer screening. So then they asked if I would help them organize a breast cancer screening sort of event. And so I did that. I didn't say a word. I just sort of empowered others to do it. And then help connect people to, the Mayfair Diagnostics, who's hosting a night with food, et cetera, cultural brokers, interpreters, et cetera, and it's going to be a safe space for them to go for breast cancer screening. So this is how things have evolved in my life clinically. And then from a research point of view, at our research program at the University of Calgary, we have a community scholar program. So this is where we hire people with lived experience, we train them in research and sort of elevate them that way, give them skills that are marketable in the future. But they also provide us with that community connection.
I suppose I didn't think I was going to answer this question, but as the community or a member thereof, we're forever getting requests to put up posters and direct people to research studies. And I think what we've learned works really well is Dr. Pam Roach is here, and we've been working at building a relationship. She came down to talk to us and invite us to get more involved with the Health Equity Hub. I think that sometimes not-for-profits in particular, of course, social justice is a part of our work, but so is enumerating the impact of our work. We're very much interested in having meaningful and substantive conversations about research. We just welcomed our first ever data and impact analyst at the Women's Centre 3 weeks ago. And so I think just to be on the other side of the equation, I think there's no shortage of researchers engaging us for extractive purposes. And I think just from a decolonizing lens, to constantly be the source of data, but to have no other contact with researchers outside of that can be a demotivating factor. So I think it's been great for us to participate with the Health Equity Hub and to come to events like this to help build those relationships.
Mm-hmm. Yeah, I think one of the most exciting parts of the work of being a community-based scholar is just putting different sectors around the same table. People who are not talking to each other. They're all doing amazing work in their own sectors, but they're just not collaborating. So I think for me as a researcher, that's the best. It's like, how do we collaborate it through projects? But I must say, there's a lot of fear these days. I think it's so important to acknowledge that. In places like Alberta specifically, I've been invited and uninvited from giving webinars, presentations, for the fear that organizations might get into trouble. right? The fear of talking about EDI, the fear of talking about
Right.
equity, the fear of talking openly about these issues, even in our own province here of Alberta. So it's unfortunate. However, when I engage with communities, especially people with lived experience, people with intellectual disabilities, what I hear very often is that people want more than just risk and harm. People also want pleasure, the positive parts of health. Like, how do we strive to having an intimate or sexual life that we desire, that we feel good about? So the two requests I got recently, for example, from community members was one, like, how do you talk about sex toys as an assistive device that should be funded? Or is it okay for me to have a relationship with an AI-generated human? Like, these are the questions that people in the community are actually asking me. They're not asking me about STIs. They're not asking about unplanned pregnancies. They already get so much of information. But what about the pleasure? So what people are consistently saying is we need more pleasure and, pardon my language, but that's what people are saying, fucking. So one participant even said FF, fun fucking. So I think that's what people are looking for as well.
Awesome. I'm sorry, I know I did not get to all of the questions. Perhaps you can all find time to come find the presenters during lunch for the questions I didn't get to. We're coming to the close of our presentation, so I just want to thank all of our presenters, Lana, Lee, Alan, and Lauren, for your insights and for all the thoughtful questions from the audience. Again, apologies that I couldn't get to them all. And then just a reminder, you have Post-it notes on your tables. So please take time over lunch to take a look. And we invite you to participate in the active installation, which I think is just on the side of the room there. So if you can take time to write your response and add it to the poster board. Your contributions will inform ongoing University of Calgary work to improve reproductive health policy and practice. Together, we can continue to reframe women's health as public health, ensuring more responsive care, stronger policy, and healthier futures. And so with that, the morning closes. Please enjoy lunch, and we'll see you in the afternoon. Thank you.